Good morning.
Morning.
Welcome to the next Grand Rounds. Today we have Lauren Garges with us. She graduated with her Master's of Physical Therapy from Arcadia University, and she has 12 years of women's health experience. She's board certified in women's health physical therapy by the American Board of Physical Therapist Specialists, and she practices at our Alex Mill facility, I'll turn it over to her now.
Thank you.
There you go.
Good morning. Thanks for coming out early. I'm not a morning person, so I appreciate everyone coming out. I've been with St. Luke's for about almost a year. I was with actually Lehigh Valley for about 10 years prior, and I've done exclusively pelvic floor dysfunction treatment for about 12 years as a result of some of my own personal experience that I had after my daughter was born. So I always appreciate when non-pelvic therapists want to hear a little bit about what we do, because I know this topic can be a little bit uncomfortable for some people. Sometimes it's a little polarizing. You don't want to know anything about it. I know Julie Spencer did a Grand Rounds maybe 4 months ago or so about pelvic girdle instability. She did a great speech. I think I recognize some faces. You guys were there. So she did a good bit on anatomy, and so I'm not going to put a lot of uncomfortable pictures up here for you. I have a really quick anatomy review just as kind of a refresher. My thought for today was to make sure that you feel comfortable speaking a little bit about what pelvic floor therapy entails, because I think it's important that we can speak to some of our niche practices within PT world. If you have a patient that you might think could benefit from pelvic PT, or perhaps there's some things that you yourself can kind of grossly assess and figure out if there's some things that might be going on, that's always helpful. So my thought was, we'll go over a little bit of a brief anatomy review. We'll talk about some of the conditions that we treat, what treatment entails, because that's the question that I often get from PTs is, what the heck do you do? What's treatment? Like, what is pelvic PT? So we'll go over a little bit about that. Then I'm going to switch gears. Then we're going to talk about really some orthopedic conditions that might come to you with an orthopedic diagnosis on the script, but it might actually be driven from the pelvic floor. So as you kind of treat these patients, and if they're not progressing, you might be able to kind of go through differential diagnosis a little bit and say, okay, this might be more a pelvic floor issue. Then you can give me a call, and we can kind of talk through that a little bit. And then we'll do a little actually interactive kind of learning experience here. Make sure you all know how to use your pelvic floors correctly. So get started here. Now that's from Steve. I put that on. So real quick, like I said, as far as the anatomy, the pelvic floor is a global statement. Really, if we think about the bony anatomy, those are the landmarks that we're often looking for. That's actually on the next slide. We're talking about really what's called the pelvic outlet. On here, it's called the pelvic inlet. I tend to call it the outlet. So we think about where the baby's head is descending during birth here. But the landmarks, as far as the bony landmarks that we're looking are, the pubic arch is in the front, ischial tuberosities. There's a landmark here called the ischial spine, and that's really a surgical landmark, but it's also something that we palpate very often to kind of help us to identify where we are. So the ischial spine is right here, and then the coccyx in the back. So it's kind of the soft tissue that really forms like a hammock or a sling or a trampoline of muscular support within that bony kind of circle that we see there. And here is another view of that. So now the pelvis is actually flipped. So now we, at 12 o'clock, we have the pubic bones, and at the bottom, at 6 o'clock, you'll see the coccyx and the sacrum down here. So the pelvic floor muscles are really called the pelvic diaphragm, and I'm going to use the word diaphragm a good bit today. So just keep that in mind. We're talking about the lowest diaphragm in the core, known as a pelvic diaphragm. It also goes by the other name of levator ani, which I think is one medical term that actually makes logical sense if you think about those words. So it will elevate, the anus. So this is these are the muscles that I'm referencing when I'm talking about the pelvic floor within these boundaries here. And there's 4 of them, as you can see here. So they all work as a group. I often tell my patients, don't really get caught up on names or thinking about, which muscle I'm working. Picture them like your quads. You're going to contract your quads. 4 muscles are tightening at the same time. That's how our pelvic floor works. There are some associated muscles. Whoops, what did I do here? Piriformis, Obturator, internus. And they're located, this is your piriformis right here. the obturator internus is in here. The obturator internus is a big driver of orthopedic pain, and I'll talk a bit about that. And that is best palpated internally. That is the gold standard, but you can palpate it externally. I'm not really going to get into palpation a little bit externally today, but I can certainly, if anyone has questions as I get to that, we can talk more about that. The fibers of the pelvic floor, 70% of them are slow twitch fibers. So what I tell my patients are, these are your marathon runners. So 70% of our pelvic floor muscles are endurance muscles. They need to have tone. They need to be working all day long. So they go, go, go. And so those are what help us get to the bathroom in time. If we're driving in the car and we have an hour to go yet, you better hope your pelvic floor slow twitch fibers are working properly so that when you stop the car and you walk in, they have the endurance to get you there in time. The fast twitch fibers, though, those are the sprinters in the Olympics, I tell my patients. So these muscles, if you cough, if you sneeze, if your kid is crawling down off of a stool, you're going to reach for them quickly. We're hoping that those fast twitch fibers engage very quickly. They can shut everything close so nothing escapes. So this is how we kind of divide the muscle fibers up. So the majority, obviously, are your endurance muscles, which kind of makes sense as we're all sitting here right now. We're all staying continent because our pelvic floor is engaged. Slightly. So when I'm treating these patients and I'm kind of having them work on muscle strengthening Kegels and variety of exercises, I need to work on both types of muscle fibers. So in order for us to really hit 100% of them, we're going to have them work on endurance holds, but we're also going to have them work on real quick holds as well, and then combining them with functional activities and things like that. So just a little bit about kind of, how we would address the different muscle fibers there. The functions of the pelvic floor, I often reference the 5 S's of the pelvic floor. I like this picture. This is a really old picture, but I really like the idea here of the shelf. So really, the pelvic floor is our support for our viscera that are in the pelvic cavity, for really everything in the abdomen. So they are relatively small, but they're really quite strong muscles. There's a sphincteric role, and the sphincters are voluntary and involuntary, especially if we're talking about the rectal sphincters. You have 2. You have one which is voluntary, which can get damaged, surgery, childbirth, things like that. And then there's the internal sphincter, which is not something we have volitional control of. So if that sphincter is lost, and you've also lost your external sphincter from childbirth damage, the only thing you got left is your deep pelvic floor muscles. So those are the challenging patients that may come through that we're seeing with some fecal incontinence, and we really need to work on pelvic muscle control in that case. Of course, there's a sexual role here. I could not find the picture, but years ago I saw a picture of the bony pelvis, and everything was removed except for the nerves, and it literally looked like a bowl of spaghetti. I mean, there's just incredible nerve innervation in this part of the body. So, something to keep in mind, there's a lot of potential for pain and kind of nerve disruption in this part of the body. Of course, it plays a role in stability, and I don't think that's a secret to any of us. The pelvic floor attaches from the pubic bones to the tailbone and the coccyx. So one thing I meant to do, and I forgot to do, is have everybody kind of cup your hands together, if you can, like this. And that's literally about how big your pelvic floor is. So if we're looking at the fingertips, that would be the attachment on the pubic symphysis in the front. If we look at our ulnar styloids, kind of where they're close to connecting back here, that's the attachment on the coccyx. And then your thumbs are kind of the obturator fossa on the side. So this is about how big your pelvic floor is, but quite strong, small, but really strong. The stabilization occurs really on the back end where ulnar styloids are, where they attach to, again, the coccyx and the sacrum. And then, of course, there's pubic bone stabilization happening in the front. But they also play a role with your abdominals, kind of dealing with intra-abdominal pressure with positional changes and things like that. And they help to stabilize the trunk with like upper extremity movements and things like that as well. And finally, a sump pump, which is not something that we talk about a whole lot, but if you are contracting and relaxing your pelvic floor, you're really moving lymphatic fluids, through the pelvic region into the lower half of the body. So certainly important for waste removal and things like that in the lymph system. So there is that final S function there, the sump pump of the pelvic floor there. So I love these pictures. I use these a lot with patients of mine. If you have your hands cupped, that's that great analogy of a hammock. And so we reference the pelvic floor hammock often. So really the two types of dysfunction, very grossly saying the two types of categories that we see are either pelvic floors that are have too much mobility or have too much stability. And so we can see on the hammock over here, a droopy kind of falling down as a result of gravity or having lots of babies or aging or surgical issues. That's kind of that lax and loose pelvic floor. A taut pelvic floor is one that is too tense, too tight, non-relaxing, and often painful. And so the happy medium is in between. And this is what I'm often telling my patients. You don't want it too loose, you don't want it too tight. We really want it kind of in between. I use a trampoline analogy a lot with patients as well, but I like these pictures a lot here. So the one that has too much mobility, these are my patients that are coming through with weakness. So this, again, I touched on it a little bit. It does increase with age. It does increase with parity, so the more children you've had. We do tend to see this more in women, I do have to say. The symptoms, these are our incontinent patients. So these are patients who are fairly straightforward as far as a weakness issue usually. And we will see pelvic organ prolapse in these patients as well. And I do see that quite a lot. So the most common organs that are prolapsing are usually the bladder and the uterus. And they are literally visible outside of the body. They're hanging out of the body. So the patients come in, they sit down, and they say, I feel like there's a golf ball between my legs. And I'm like, okay, I really don't even have to do an eval. I know what's going on. So we can usually tell that that's probably likely what's happening as the prolapse is occurring. If they can literally feel it to that degree, they might need a little surgical correction before PT is going to be real helpful. I mean, I'm not a magician here. So I have to call usually the referring doctor and say, this is a little bit too far gone. We have to be very realistic on what our exercises are able to reduce when it comes to that severe of a prolapse. So it's rare that we'll see that. Would you agree, Kylene? I mean, it's getting better. I used to get tons of referrals of grade 3 and 4 prolapses, which are pretty far gone. And now we've kind of educated our doctors that we do best with grade 1 and 2, which is like the lower level prolapses. We catch them earlier. We can, talk about strengthening and prevention and body mechanics and things like that. Eileen's here, by the way. She's 4 days overdue, so if she's in the right spot. Eileen's at our Easton office, the other pelvic floor therapist. And Julie, our other therapist, is on vacation right now. So there's 3 of us in the network that treat this. The pelvic floor that has too much stability. So these are the patients that are coming through to see us with usually pain. A variety of reasons. It was a result of surgery. It could be childbirth issues that happen. There could be trauma. There could be an MVA. Unfortunately, we do see some abuse cases as well sometimes. Pain can also come from the viscera and from the organs within the pelvic area and the abdomen. So a couple conditions that we often see. One is called interstitial cystitis, and this goes by the term of painful bladder syndrome. So these patients, they actually literally have pain in their bladder, and it's very painful. There's actually hemorrhages along the lining of the inside of the bladder. And so, as you can imagine, acidic urine, as it fills a soft tissue that has hemorrhages in it, it burns, it aches, it's very painful. And so they're going to the bathroom often every 15, 20 minutes, because as soon as any urine enters their bladder, they are in extreme pain and they want to go. So that's one of the, the visceral issues. As a result of that, the body knows something is off. And so what does it do protectively? It splints and hugs that area. The pelvic floor tenses up. So patients then wind up with a whole conglomerate of issues as a result of this painful bladder syndrome. And from a musculoskeletal standpoint, it's often a very tight pelvic floor. Endometriosis is another that a lot of women come through with, unfortunately. Endometriosis is when the lining of the uterus actually comes outside the cervix, and then it begins to kind of coat other structures in there, whether it's the ovaries, the fallopian tubes, the bowels. So it's abnormal, but not an unusual thing, and it's usually very uncomfortable. The best way to get rid of it actually is surgery. But again, something is off. The body knows that. What happens? The pelvic muscles tense up. So as a PT, I'm seeing a lot of tension and tightness in those muscles. And then irritable bowel syndrome. I think most of us have heard of IBS, chronic inflammation of the bowels, lots of constipation, and also can involve lots of diarrhea. Again, tense pelvic floors. There are some, obviously, as you can imagine, some without great posture, some skeletal anomalies. We will often see some pelvic floor tension, typically as compared with that lax pelvic floor. We'll see more tightness there. I'm going to talk more about that in a little bit. And dysfunctional voiding patterns. This is something that we see a lot of as well. And really, this is in reference to people who have developed some not very optimal bathroom habits. And so sometimes the best analogy are some of those ladies who get together for lunch and they kind of all go to the bathroom before they sit down on the table, whether they have to go or not, right? They're all just going to go to the bathroom and then they're going to be happy and they're going to sit down. Or they go to Wegmans and the bathroom's clean, so they're just going to run in there and use the potty before they go shopping. They don't have to go, but they're going to go because it's there. And so we call that going just in case. So it's the PT term is jick. And so we always tell our patients, don't jick. And we do this with our kids, right, guys? Go to the bathroom before you get in the car. We have to drive for an hour. Like, don't, just go empty your bladders. I can understand with little ones. That's I do that sometimes myself. But if you yourself are running out to an errand and you have to go to the pharmacy and then run to the grocery store and you just emptied your bladder 20 minutes ago, don't empty it again right before you run out the door, because what we're starting to do is we're starting to develop dysfunctional voiding patterns. Your bladder is not sending you a signal. It's not sending a signal to your brain that it needs to be emptied. And so if you empty it when it's not sending you that signal, the bladder starts to believe that it should be emptied more often. And so this is how we start to fall into overactivity, overactive bladder, hesitancy. Sometimes that begins to happen because people are tense, they're driving, they're tightening up their pelvic floors, they're nervous, they're not going to find a bathroom. There's a lot that goes on in the brain when it comes to this. So this dysfunctional voiding pattern is something that we see a lot. So we spend a lot of time. I always say I have the luxury of time, I think, with my patients to sit down, talk to them about their bathroom habits, have them fill out like a maybe 3-day bladder diary where we can review how often are you going, what are you drinking, what stresses you out, and how can we change your behavior a little bit. So, but these patients are often tense as well, just often because they're like a little stressed about it. So symptoms, I'm talking a little more about the non-relaxing pelvic floor here. Some symptoms that we might see. Some patients do present with pain with urination, as you can imagine, if they have some of those other visceral, issues going on. It can burn. It can be very uncomfortable. They may have what we call a shy bladder, or there might be some hesitancy there. So if they're in a public bathroom, they literally cannot empty their bathroom or their bladder. The muscles are so tense that they literally can't go and must go in a private area. So that's really not very convenient, and it really affects your quality of life. Chronic constipation, I already talked about that a little bit. We'll see paradoxical muscle contractions sometimes. So when we should be emptying our bowels or emptying our bladder, what happens is everything should relax. It's just kind of we should not be pushing or straining. And often what happens is what we'll see is that a patient instead of relaxing, their muscles are tensing up. And I see this on biofeedback, or I see this with palpation. When I ask them to relax, they can't quite figure it out and they're like bearing down or they're contracting. And so that's kind of that paradoxical muscle contraction that we'll see there. Dyspareunia is the medical term for pain with penetration. And this could be with an examination, this could be with tampon use, this could be with a partner. It's a huge quality of life issue, as you can probably imagine, and it's a good percentage of patients that we see that come through. Really, women need to be able to have exams. I mean, really, just to be able to make sure everything's healthy. So even if they're don't have a partner, we need to make sure that they can see, a GYN to have an examination. So, this tight, taut pelvic floor often does not allow anything to enter, and that can be quite devastating. So, that's a category that we'll see a good bit of. Chronic pelvic pain is a big global term, kind of covers a lot of different diagnoses. The main hallmarks of chronic pelvic pain are patients who've had pain for more than 6 months, and it has not really responded to traditional care. So usually medications that are prescribed for this issue are not very beneficial. There's not a lot of findings on examinations that are done traditional, radiology reports and ultrasounds and blood work. Doesn't typically find a whole lot. They'll go to the doctor and the doctor says, I don't know, I don't see much. You look fine. And my answer to that is, well, we don't see nerves. You can't see nerve disruption on an examination, and that often doesn't show up on a radiology report and things like that. So we need to recognize that sometimes these patients will come through to us and they've seen many, many, many specialists, and they're just like, they're overwhelmed. Then they start to get into a little bit more of its central sensitization and start to upregulate, and it can get to be quite debilitating. So these patients are challenging to work with, but they are among my favorite because we kind of have to sleuth and kind of piece out what's going on. And when we get some results, it's really rewarding. Often these patients don't just have pelvic pain. So they'll describe low back pain, they'll describe pain in the inner thighs, buttock pain, things like that. Those are patients you may also be seeing as well. And they may not be telling you that if they have low back pain, that they have concurrent pelvic pain as well. So it might be good to ask some questions along that regard. So what do we do when a patient comes in and we're doing an exam? There is a pretty extensive history, I will say. My history taking takes probably a good 20 minutes with many of my pelvic floor evals, just because there's a good bit to kind of talk about. We need to talk about their OB/GYN history. We need to talk about, of course, what their current symptoms are. We need to talk about the bladder. We need to talk about how they're hydrating. We need to talk about their diet. We need to talk about their bowels, their activity level, what they do for work. So there's a lot to go over in an evaluation as far as the history taking. We do have 2 consent forms. They have the regular consent. There's also a pelvic floor specific handwritten consent that our front desk also signs that has given us permission to do an internal examination on them. I am an orthopedic physical therapist, so I do an external assessment as well first, looking at posture, range of motion, strength, and just like you guys do, we'll go through that. And then, more of the internal assessment is primarily looking at vaginal tone, strength, trigger points, laxity, endurance, comparing right and left. It's very rarely the same. Usually that one side is different than the other if they're coming in with some type of pathology or some type of dysfunction, and sensation and reflexes. And biofeedback assessment is part of our examination as well. So biofeedback, most of us, I think, are familiar with biofeedback. If you went to school maybe 2005 or 6 or later to physical therapy school, you might have had biofeedback in school. I didn't. So I had no pelvic floor training in my PT training, but I think some of the newer therapists probably within the last 10 years maybe had a lecture or two on this. Is that true? Anyone? When you were in PT school, did you learn a little bit of, yeah. I've heard that the lab portion of this usually involves a volunteer to put an internal probe in order to kind of look at the biofeedback, and then no one volunteers, and then the professors just pick somebody out of the crowd. So I don't use internal probes very often. I used to. But they're uncomfortable. So they really I'm trying to see if someone can relax. There's a probe inside them. They're not going to relax very well. So I now use mostly superficial external electrodes, similar to what we do for a heart EKG. And we put them actually by the external sphincters, the anal sphincters. And we can really measure muscle activity. So we can see, can you do a Kegel? Does it relax? How long can you hold it? We actually visualize this on the screen together with the patient. So it's not like a diagnostic ultrasound where you have no idea what they're looking at. I'm actually using it as a learning tool and showing the patient what's going on. So that is helpful. I use that with most of my patients, whether they're coming through with pain or weakness. The biofeedback can be a really great tool to do that. So what do we do for treatment? Again, I do have biofeedback on there. So biofeedback is my eval tool because it gives me objective data. So, we have the normal values, and we can see how they compare with normal values as far as strength and relaxation, things like that. But then again, it's a treatment tool as well. We do a lot with relaxation, especially those patients that have that very tense, tight, taut pelvic floor. Breathing techniques, visualization, stretches, things like that. Dietary recommendations. Some people, I think, are probably surprised to see that up here. Is that within our scope of practice? Absolutely. If someone does have those dysfunctional voiding patterns and they are, going just in case all the time, or they have an overactive bladder, and I'm asking them, well, how much water do you drink a day? And oh gosh, I don't drink at all. I don't want to drink. I'm afraid to drink, or maybe a cup a day of water. Think about how concentrated that urine is, and how irritating that urine is. It's so acidic. Well, it ends up being a vicious cycle. The bladder's like, get this out. Like, it's so irritating. So that perpetuates that overactivity. So absolutely, we need to talk about the diet. And I see a lot of patients with constipation. So we do need to talk a bit about what they're eating, fiber, and kind of their activity levels and things like that as well. So we spend a good bit of time talking about diet. Electrical stimulation, I don't use this a whole lot. If someone really is just not progressing as far as from a strength perspective, and they just don't have very good kinesthetic awareness down there, they just can't quite get it, and we're working and they're not really able to contract their muscles, I may use an internal probe, and that is electrical stimulation that will actively contract their pelvic floor for them. I have had this done, as we all have PTs, and we've, every technique we do on a patient, we've experienced ourselves. It is not particularly comfortable. It's not my favorite thing in the world. But I think if I had severe bladder incontinence, I might be willing to go through it. So most of my patients have said that. So the Easton, and we'll often get them a home unit that they can do this at home once they learn what it feels like in the office. Ultrasound, pretty rare, but there is some pretty good research out there showing it can be effective on episiotomy scarring. So I've had some really nice results with patients with some scarring. So I will do a little bit of ultrasound sometimes in the perineal body where an episiotomy would occur, and then follow that with some soft tissue work. So it's not very often, but I will use that occasionally. Dilators are kind of stretching tools that we'll have patients get. They're not covered by insurance. They are for patients that have that dyspareunia, they have that pain with penetration. They start very small, and they actually, for women, they basically look like a tampon applicator, to be honest. And these ladies work on trying to insert them a little bit so that maybe they can tolerate an exam, or they can tolerate a tampon, or they can tolerate a partner. And they get larger and progressively larger. My protocol with dilators is, and I have the patients bring them in, and I go over use with them kind of every other day, and they stretch for about 5 or 10 minutes with them, and they do not progress to the next size until they are pain-free with whatever size they're using. And they go up to size 6, so it starts very small and goes up to a fairly large dilator, like a human size dilator. And they can be a really nice adjunct to what I'm doing in the office if they're stretching with those at home. Bladder retraining, that's kind of the idea of those patients who are going too often. I'll say, okay, if you're going every 20 minutes, let's see if we can have you set an alarm on your phone and see if you can stretch it to 25 minutes, like just little goals. And this week, that's what I want you to do. I want you to go every 25 minutes. And then when they come in the next week, all right, let's see, maybe we can go to 35 minutes. We're going to see if we can stretch this out. Normal voiding, if someone is hydrating well, would be every 2 to 4 hours. And that's men and women. So, that's kind of the goal that we work toward. Usually 2 is my goal. If we can get someone with overactive bladder just to kind of get to an interval of every 2 hours. And then there's a lot of manual therapy. So I think we would really consider ourselves hands-on manual therapists. So a lot of soft tissue mobs, a lot of trigger point releases, myofascial release, work on scars. I'm trained in visceral manipulation. The term is called manipulation. I actually like to call it mobilization, and it's really soft tissue release of the organs in the abdominal cavity. So that can be really helpful with patients who have constipation, and also some pain in whether it's the uterus or the bladder. So it's very gentle, done through the abdomen. It's not like I'm manipulating these organs, but it's a fascial release. I could do a whole grand rounds on just visceral mobilization and taking a lot of courses on it. But I get pretty good results with that. And of course, exercises. They're going to have homework. This is not passive treatment. There's going to be things we're doing at home. I see patients, I think Eileen's the same. We see them once a week or once every other week. So there is a lot that they need to be doing at home, and we stress how important that is when, on day one, really. Now, switching gears. So that's kind of what pelvic floor therapy is. That's kind of hopefully a little bit of an understanding of what we do if you didn't know that before. But I wanted to talk about really kind of, again, some of the orthopedic conditions that you might be seeing. And as you're working with these patients, just kind of keep in mind that there can perhaps be some underlying pelvic floor involvement as well. So lumbosacral radiculopathy, this is one, many of us are seeing a common diagnosis to come through the doors. And, you've got your patient who has some radicular symptoms going down, and we're fairly certain that it is coming from the nerve roots. You want to keep in mind, and I actually realize I haven't talked too much about this particular nerve, but if we look here, we can see big sciatic nerve right here, and then this nerve right here is called the pudendal nerve. That's our nerve as pelvic floor therapists. So the pudendal nerve comes from S2, 3, and 4. It innervates the genitalia, it innervates the deep levator muscles. So the sciatic nerve and the pudendal nerve share nerve roots. Sciatic nerve L4 through S3. So, there's crosstalk with shared nerve roots between nerves. So if they've got some sciatic pathology going on, they may very well have some pelvic floor symptoms as well. So you want to just ask those questions and keep that in mind as you're working with these patients. If the sciatic and radicular symptoms are resolving, but they're still continuing to kind of have some more localized complaints here, as you're thinking, oh good, it's it's kind of localizing and centralizing, it may be that pudendal nerve is still somewhat irritated. It may be that the pudendal nerve is actually the driver of the pain. So kind of keep that in mind. So the pudendal nerve is an important nerve for the pelvic floor. Piriformis syndrome, also one that we see often. That I kind of put this picture back up here again of the pelvic floor, just so you can kind of see where the piriformis relates to the pelvic floor again. So here we've got piriformis muscle. This is all pelvic floor muscle, tailbone's right here. Here's your piriformis, the external rotator. This is a muscle called the Obturator internus, also a hip external rotator. And here's your pelvic floor muscle on the right side. This whole area shares a fascial sheath. So if there is something going on in the obturator internus, it's very tight, there's spasm, there's trigger point, something going on there, it will very likely affect the pelvic floor laying there immediately. Same thing with piriformis, and these can affect each other. So we want to keep in mind that if you're working on your piriformis patient and you're in there and you're hammering it and we're doing all kinds of soft tissue work and we're stretching, there may very well be some pelvic floor involvement as well. And if we go back to this picture, keep in mind, here's your piriformis. Here is the obturator internus, these two muscles. The sciatic nerve is kind of sandwiched in there. So the obturator muscle I mentioned earlier, big muscle, we can palpate it internally and we can often release it. If a patient comes in and we're thinking they have pelvic floor involvement, we're thinking, I'm going to work on the coccygeus muscle or iliococcygeus muscle, which are pelvic floor muscles, and I work on them and they're not tender at all. Often what I do is go to the obturator and they may jump, and that's the driver of their pain. So so the obturator internus, like I said, it's an external rotator, something to kind of keep in mind. I can, if you want to know how to palpate it externally, I can go over that with you. It's done kind of through the I don't know how to say it, leg spread, closed, but you can get in there. So we can kind of go over that at some point. I'd be happy to talk to anyone about it. Sacroiliac joint dysfunction. Of course, the pelvic floor attaches to the sacrum. So, that certainly can cause a little bit of shifting of the sacrum, depending, because the pelvic floor often is not tight symmetrically, unfortunately. It's often one side, the right side, or the left side that can be pulling. Thinking about those postural abnormalities we might see kind of that there's some pelvic asymmetry going on. It'll affect the way the pelvic floor muscles lie. That can lead to some SI issues as well. Also, one thing to keep in mind, there's a ligament called the uterosacral ligament, and it goes from the uterus to the upper borders of the sacrum here. This particular picture actually is, this woman does not have a uterus anymore. She actually had a hysterectomy, but there's something called a vaginal cuff that remains. That's what we're seeing here. But I like this picture because it shows the ligaments really nicely. You can see where it attaches on the inside border of the sacrum. So if that ligament's tight, oh my goodness, yes, they're going to have SI joint dysfunction. So something to kind of keep in mind as well. We kind of get into some postural techniques in that regard to see if we can kind of help to mobilize that and move that around. And there can be some surgical issues as a result of some gynecological surgeries that can cause some scarring, some adhesions. Sometimes women have mesh in place to help with those prolapsed bladders or prolapsed uteruses, and the mesh can shift around a little bit. So these patients often present with SI joint pain. Your patients with hip pain, impingement or arthritis, you want to keep in mind that there are fascial connections, like I mentioned, between the obturator internus and that piriformis and the pelvic floor. So that kind of fascial sheath. There is also a fascial connection with the inner thigh muscles and the pelvic floor as well. And so trigger points right here, the adductor magnus is a big driver of groin pain. So if you, especially in men for some reason, and we do treat male patients, if you have a male that comes through and he's saying he's just got this kind of unrelenting kind of groin pain, or maybe pain where like that skin fold is and the hip crease here, sometimes they'll say they might tell you they have rectal pain. I'm telling you, check out the adductor magnus. Very often there are trigger points there. They are not typically symptomatic there. They don't even know that they have anything going on. But when you palpate it, they may very well jump off the table, and that may very well help to release some of their pelvic floor tension and tightness. They will think that you are the smartest person on earth if you go to the adductor when they're coming in saying their rectum hurts. But it really can be a really big driver of that deep, deep pelvic pain. So we find this a lot. If I have a patient with any type of pelvic floor dysfunction, any type of pelvic floor pain, I'm always going to check out their adductors. So just something to keep in mind, because they share that sheath of fascia. So you release that, and often it can help to release some of the other internal pain that they may have as well. So obviously patients with poor posture, obviously that's going to affect kind of the abdominal pelvic canister here. So there is a synergistic relationship between the thoracic diaphragm and the pelvic diaphragm. So that word diaphragm, I'm going to keep that in mind. I'm going to talk about that a little more in a minute. But if you've got your teenage posture, as I like to reference it, or like the cell phone posture, right? And we want to think about our diaphragms here. How well is this diaphragm expanding if someone is really kyphotic here? So as an orthopedic therapist, you have a huge opportunity to work on postural improvements, on mobilizing the thoracic spine, check out the ribs, make sure we're making things optimum to open up within the core canister, top and bottom of our core canister. We talk about core stability, core training all the time. We talk about the abdominals, the multifidi, the back muscles, but sometimes we forget the top and bottom of the core. Top and bottom of the core, thoracic diaphragm, pelvic diaphragm. So I'm going to talk about that a little more in a minute. Coccydynia. This is very often, in my opinion, I think orthopedic therapists are going to get this across their table more than we do necessarily. And I think sometimes everyone's like, oh my gosh, what do I do with this? You can palpate the coccyx externally in prone, put a pillow under them, and get your hands there. Don't be afraid of this bone, that little triangular bone on either side of it. I should have put a picture, but there is a muscle called the coccygeus muscle. It is easy to release. And so you can certainly kind of mobilize and work on soft tissue work on that coccyx there. So that's something that very simple to kind of assess and treat. And then what you want to do is get them into some good stretching positions and kind of work on some cushions and things like that to kind of unweight the coccyx while it heals. But it sometimes needs to be mobilized. In that case, if you're not comfortable, you could call one of us. We can do a rectal coccyx mobilization if necessary. But I really feel like maybe only 25% of patients with true coccydynia need that mobilization. So it's very often something that we can address, an orthopedic therapist can address themselves. And diastasis recti. Does anyone not know what this is or never heard of this before? Can I ask that question? Or have most of you heard of this? This is something that I wanted to put in here because I think this is really under-addressed. And the idea with diastasis recti is that this is a condition that occurs primarily during pregnancy. We're looking at the linea alba of the rectus abdominis muscle, and the research shows that 70 to 95% of pregnant women have a diastasis recti. So if Kylene were to stand and we saw her center of gravity now out here, you can imagine what's happening with the rectus abdominis muscles as the uterus is expanding anteriorly. They separate. This is normal. This is not like, oh my gosh, this is not like an abnormal finding. What's not normal is if that postpartum mom comes in to see you 5 months later and she still looks pregnant. And this is often more evident in women who are a little more trim and fit, frankly. We'll see it. And they've gone back to some exercises and they're like, I can't get rid of my baby pooch. Like, what is going on? Very often, their linea alba has not come back together again. And so this is what we see. So this is so easy to assess. And I would say if you've any mom come through who has had a baby within the past year, put them in hook lying on their back, knees bent, have them do a crunch. And what you're doing is you're palpating with your fingers kind of horizontal like this, above the umbilicus, at the umbilicus, and 3 inches below the umbilicus. And what you're feeling for is a cavern in there. So your fingers will fall into that separated linea alba. It should feel taut. It should feel taut and you can kind of feel on yourself. It should feel like it's together, unless you have a diastasis. It's amazing what I had a woman yesterday. We measure in finger widths. That's kind of how I document like the size of it. If it's more than 2 fingers, we consider it significant. So my patient yesterday, she came in 2 weeks ago. She had an 8-finger diastasis at 3 inches above the umbilicus. It was on her eval. I was on vacation last week, so she came again yesterday. So 2 weeks of doing her exercises, she went from 8 to 6. So I thought that was pretty good, 25% reduction in 2 weeks. I thought that was pretty decent. So, so we're working on trying to get this soft tissue to come back together. I would love if we could do this because I think so few orthopedic therapists address this. And think about core stability, right? If this is happening here, then they're going to have back pain. They're going to have all kinds of issues, hip pain, all kinds of stuff going on. It's not hard to assess, and it's not hard to treat. So if it's very severe, I may very well put them in a binder. If they have like a job where it's pretty laborious, they have a lot of manual things they need to do, I may put them in a binder for a short period of time. But a lot of the exercise that we do actually involves kind of manually compressing that linea alba together. Again, this towel or sheet exercise is very common. So she's basically doing a crunch here, and make sure she's going to be exhaling as she's lifting her head, and she's crisscrossing a sheet and pushing that linea alba together. Sometimes I just have them do it with their hands and just kind of compress as they engage their rectus muscles. So you're manually placing it in its optimum alignment while you engage the muscle. This was the only exercise that I gave my patient that day of the eval 2 weeks ago. She's only done this exercise for 2 weeks, and she's already reduced it by 2 fingers. So it's pretty neat. There's more exercises than this, but this is one that I find is very, very helpful. Again, remember that these women are often kind of trim and fit. They're the ones that we'll often see it with. And so sometimes they're working hard on their own. They're doing crunches, they're getting on the ball, they're doing planks, they have legs up, they're doing bikes, they're doing the Pilates 100. No, none of those should be done, because think about what's happening if they're doing sit-ups, right? They're basically herniating this all the more. So unfortunately, they've probably been making it worse as they've been trying to address it themselves. So there are certainly activity and exercise restrictions that we want to place on these ladies and kind of guide them through safe exercises to bring this stability back in these muscles. So those are really off the table. If you want more information, or I'm happy to do an in-service on diastasis, I think it's something that's really undertreated. And these women, one more thing, my little soapbox here, OBs do not look at this, ever. So when you have a baby and you go back for your 4 to 6 week check, and they check your internal stuff, and then they say, okay, we'll see you when you're pregnant again. These women are not being served in a good way in regard to this. So as PTs, we have a great opportunity to really assess for this. So, to Kegel or not to Kegel, right? So I'm kind of shifting a little bit here too, but I wanted to talk a little bit about the pelvic floor, and I want to make sure I leave time for questions, so I'm going to hurry here real quick. We talked about the two types of pelvic floors, the hammock, right? The really loose hammock or the really tight hammock. Thinking like, okay, what do I do with these patients if they come through my door, and you as an orthopedic therapist may have an opportunity to help them to work their pelvic floors a little bit. Should you have them do Kegels or not? Doctors almost always will say, yes, Kegel. If you're leaking, oh my gosh, do 100 Kegels a day. Well, guess what? If that patient has tension and has non-relaxing pelvic floor, that non-relaxing pelvic floor is also usually weak because it's never getting a break. So it's tired. So she may be leaking as well. And she's doing 100 Kegels on a pelvic floor that's already tight. She's making it worse, and she's leaking more, and she's getting nowhere. So those particular patients who have chronic pain, the patients who come through, you can kind of tell. I was hesitant to put that type A personality in here, but I will say I do tend to kind of see that with your patients who are kind of, they carry stress in their body. They're just that kind of hyper personality. They're that type A. They are better to probably not do Kegels with if you think there's any pelvic floor involvement. You may well do some stretching, some relaxation exercises, some breathing activities with them, and maybe give one of us a call if you really do think the pelvic floor is a driver. I would not instruct them in pelvic floor exercises. But if someone comes through and you're like, oh, they're generally, they've got that poor posture. They don't have a lot of tone going on in their core. They've got a lot of instability going on. They may very well benefit from you and teaching them a bit about Kegel muscles, their pelvic floor muscles, and engaging them and incorporating them into their exercise routine. So how do we do it, right? How do we teach our patients how to do a Kegel? So I would like everybody to sit at the edge of your seat. I usually do this laying down. We typically do this with a patient on the plinth in hook lying position, knees bent, or I put a support underneath them. Hopefully most of us have decent enough body awareness that you can do this in sitting. It is harder in sitting. I would not recommend sitting with a patient because gravity has an effect on your pelvic floor. So as you're engaging your pelvic floor, you're going to be contracting it. It's going to be lifting upward and inward, obviously against gravity. So we're doing this in a little harder position. But hopefully most of us as rehab specialists have some decent muscle awareness here. So what verbiage do we use, right? What cues do you give your patient to contract your pelvic floor? Many of us have heard to stop the flow of urine. That is not my favorite term. You can use that, but actually I find patients sometimes who stop their pee every time they sit down, and then they wind up with dysfunctional voiding. So it is not my favorite. What I like to tell patients is to think about a circle. And so we're going to be kind of closing a circle at the openings at the bottom of our pelvis there. We also use the term elevator a lot. So you can think about closing the doors of an elevator, and then you're going to lift those muscles upward. So it's a very subtle tightening, tensing, and then lifting upward. You can think of this rectally. You can think of this if you're stopping gas. That's a great cue. Everyone has felt gas. Everyone's had to hold it in. That is a Kegel. So if you're holding in gas, men, I do not have this anatomy, but I have heard that it feels as if you're walking into a cold body of water and everything is kind of pulling upward. That is what a proper Kegel feels like. So that's another term that you can, or a cue that you can tell men. So hopefully everyone can kind of feel that lifting. The target is to be able to hold for 10 seconds. So 10 and kind of, what prescription should you give your patient? 10 seconds, 10 reps, 10 times. Easy to remember. That's the goal. Many of your patients will not be able to hold for 10 seconds. So again, I would have you do these probably laying down first if you think someone's extremely weak. Now, we want to incorporate breathing. Remember what we said about those diaphragms. So we've got like our thoracic diaphragm, and now you're working your pelvic diaphragm. So you want to add breath into this. And there is a picture. What's the next one? Oh, let's get this for a second. If you notice, as the upper diaphragm is elevating, so is the lower diaphragm. So this is like a pistoning system that's happening in our thoracic and abdominal cavities. As the upper diaphragm goes up, the pelvic floor goes up. As the upper diaphragm goes down, the pelvic floor goes down. So when does the diaphragm go down? The diaphragm goes down when we inhale. So as you fill your lungs with air, the lungs are expanding, the diaphragm is descending. What's happening in that pelvic floor? Remember that pistoning? The pelvic floor is going to descend. So when you inhale, your pelvic floor is generally relaxed, lengthening, opening. When we exhale, the diaphragm will elevate. Lungs, air's going out, diaphragm's coming up. What's happening with your pelvic floor? Pelvic floor is coming up. So to do an optimum Kegel, incorporate breathing into it. And so coming back here, now this is a very fast breathing pattern. I wish this were a little slower, but as you go ahead and take a nice, slow, deep breath in, if you can do it in your abdomen. Don't breathe into your chest. So we want to think about abdominal breathing. So I'll kind of show you here. It's not just chest breathing. It's not that. It's deep down here. And a little lower. As you exhale, Kegel, lift, right? So exhale, diaphragm goes up. Exhale, pelvic floor goes up. If you forget this, I always think of bicep curls. I don't know why, but it's like exercise 101, like when do you breathe? When do you breathe? So you have heavy dumbbells. You're going to breathe on the exertion, right? You're going to breathe as you're like that. So the Kegel is the exertion. You're going to breathe out as you're doing the Kegel. So key with your patients, because most of your patients are going to hold their breath when they're doing a Kegel. Almost always, because they're so focused and they may not get these muscles and they're not figuring out, and they're like totally doing a Valsalva. And I'm like, what? So it's this, and this is how I teach it. This is the positions that they'll be in. So I'll have them actually place one hand on the sternum, one hand on the belly button, so they can really feel their lower abdominal expansion and incorporate the breathing in with that, with the pelvic floor there. And so finally, you can just kind of integrate this into your exercise prescriptions that you're giving your patients. So once you feel that maybe that weak patient who maybe has some postural faults and they don't have good floor control, and now you taught them how to do a proper pelvic floor contraction with breathing, incorporate this into what you're giving them. Of course, we know all Shirley Starman's exercises. You can do pelvic floor exercises with more advanced exercises with resistance against gravity, standing. There was a paper that came out in 2010 that said the value of blowing up a balloon. I use balloons with patients a lot. Any of those who've been to PRI and done any postural restoration work, they do a lot of balloon work with that. So that's a great way to train patients. And finally, what's the take home? What are you going to apply in the clinic today? A couple things I would say. Don't be afraid to ask your patients about some pelvic floor symptoms. Do they have incontinence? Do they have pain with sitting? Do they have pain with intimacy? If you are at all comfortable asking that question, that's a wonderful question to ask. There are pelvic floor questionnaires on photo, so you could certainly give them some of those if you're not comfortable with some of the more intimate questions. Don't forget about breathing. Don't forget about trunk posture. Don't forget to kind of look at that kind of thing as you're having them go through some of their therapeutic exercises and integrating them into more functional activities. And look, listen, and feel. Don't be afraid of this part of the body. When I was in school, it was literally like a black hole. We skipped right over it. We did not talk about this at all. But I think, it's really an important, valuable thing to kind of consider with your patients. And that's it. Any questions?
So if we would refer patients to you, what things would you want to know to help you?
Often I can access your notes, so that's usually what I do.
What things would you like in our notes to help you?
Yeah, what's not progressing? What your reason for thinking that the pelvic floor is involved is kind of what I generally want to know. And, would you agree, Kylene? I mean, yeah, we do get referrals. Kylene and I and Julie, we're kind of spread throughout the valley, Center Valley, Bethlehem, and Easton. We need more people to treat this. We have probably a 4 to 6 week wait list right now for new patients to get in. Julie and Colleen's going to be out for a few months. She already is out. Thank you for coming in today. We're going to be doing an in-service, hopefully in October, for any staff who are interested in learning more about just pelvic floor therapy. I'm passionate about it. Julie's passionate about it. Colleen's passionate about it. We love our pelvic floor patients. I have to say, I feel so blessed because I see patients one-on-one. So I'm like, a busy day for me is 9 patients instead of 18, because we spend one-on-one time with them, and we really get to know them well. So it's so rewarding. So we'd love to just talk a little more about what training entails, or if you want to shadow, or we need more people within St. Luke's to hopefully begin to treat some of these patients, because we're getting a great support from the physicians. We just can't get them all in the door. So we'd love to do that. So Julie and I will be setting up a date, and we'll be sending that out to all of you, I assume, as far as the date of the in-service. That we'll try to do it over lunch. And it's not a commitment on your part by any means. It's just come in and find out a little bit more about what it entails.
What other questions you guys have?
Is there any way to assess externally if there's tightness in the pelvic floor? Or is that?
That's a great question. You can kind of get an idea with the TA. So the pelvic floor and the TA co-contract. So if they're very challenged to engage the transverse abdominis, and they do tend to fit that mold of that kind of hyper-stressed, tense type of person, there is a good chance they're clenching in their pelvic floor and that they have that hypertonic pelvic floor. But truly the gold standard is an internal assessment. You can do an external biofeedback reading as well, and that tells us that their pelvic floor is non-relaxing. Yeah, that's a really good question.
Make sure you guys sign in, and New Jersey, make sure you sign out as well. Thank you guys very much.
Thank you. Is that turned the whole time?